Is a PSA of 0.023 considered undetectable? This person has not had surgery. They've been on Zytiga and Firmagon for quite a long time. They get a shot every month, and they're kind of wondering, do I need to do something further, or is this a good spot?
Yeah, the word undetectable and the clinical relevance of having a low PSA are not precisely the same thing. Sometimes people use the word undetectable as a surrogate for saying the PSA is low enough, we've arrived, we're in a good place. I would say that a PSA below 0.1, you've arrived at a good place. The PSA is low as a result of the treatment. There may not be evidence that going lower and lower, which is you can measure down to 0.01 or sometimes 0.001, is going to translate into long-term better outcome than the person that just gets below 0.1. So sometimes people say it's less than 0.1, it's undetectable. Well, on certain assays, it may not be undetectable because that means that on the assay, they couldn't detect any PSA using that methodology. So undetectable is always signaled by the chevron sign, the less than sign in front of the number. That means that as low as that assay could measure, they couldn't find any PSA at that level. I think they said, 0.023. But there was no chevron sign, so it wasn't technically undetectable, but it's certainly in a very good range, less than 0.1. They appear to have an excellent response to hormone therapy, and trying to get it lower would not, in all likelihood, translate into some better outcome someday. They've arrived.
So that same patient is wondering if they can go on testosterone therapy. They want to get it replaced, and obviously the side effects of hormone therapy are quite extensive when it comes to fatigue and losing muscle mass. I understand why they'd want to go on. Is this a safe area for them to discover, to go into, or is there certain things that they should watch out for in the process?
Yeah, it is safe. We don't know too much about this person's case. Did they have metastatic disease on scans before? Are they newly diagnosed? Do they need to get radiation and be cured? So we don't really know the background. But in the old days, even newly diagnosed patients we would treat with so-called intermittent therapy. And these days, because radiation has become far more tolerable, we usually say, let's just try and cure it and move on rather than doing intermittent therapy. In people that have metastatic disease that want to take a holiday, studies are really clear that you can safely take a holiday. You mentioned taking testosterone. Just stopping the Zytiga and I think it was Lupron they mentioned as well, that should result in the patient making their own testosterone. They don't have to necessarily take testosterone, although there may be a delay. But some elderly men, you stop their Lupron and their testosterone doesn't recover. And the question arises, can we safely give those men testosterone? And I would argue, yes, that we certainly can. It's essentially what we're doing when we stop Lupron. The testosterone that comes from the man's testicles is the exact same chemical makeup of any testosterone that you would apply with a cream or a shot. And I don't see any difference whatsoever. PSA has to be monitored, blood counts have to be monitored for it all to be done safely, and then at some certain threshold that the doctor may specify, PSA rises up to where it was before, or to 5 or to 10 or some level, then the Lupron and Zytiga will need to be restarted. And with the expectation the PSA will go back to undetectable levels.
Now, with the testosterone, coming back into the man's body, how long does that take? Does it depend on whether it's a second generation or third generation hormone therapy?
So it's age related and treatment duration related. So the older the man is and the longer they've been on treatment, the slower the testosterone recovery, as a general rule. Now, you're probably referring to this new medication, an oral Lupron called Orgovyx, which is an attractive alternative to Lupron because the testosterone recovery rates seem to be much more predictable when you stop it. The formula that I already cited of older and longer term treatment resulting in longer delays in getting your testosterone back reportedly is not the same for Orgovyx, that the recovery of testosterone is much more predictable. So I haven't had enough firsthand experience with Orgovyx to see that in action, but that's what they're reporting from the clinical trials that were done.
So we have a 72-year-old. He has a glycinate prostate cancer. He had IMRT, and he has been on hormone therapy, and his PSA is about 0.28. And so he's wondering, should he get a PSMA scan? Is his PSA kind of, again, it goes back to that undetectable versus, is it just at a good state? And so he's wondering what the next steps are.
It'd be interesting to know how long ago he started hormone treatment. We have talked about the fact that your PSA ideally will go down to less than 0.1. This individual hasn't quite arrived at that threshold. But we didn't mention that it takes, on average, anywhere from 4 to 6 months for the PSA to float down to that level. If this is early on in the patient's treatment course, I would just wait a few more months and expect that the PSA will ultimately get below 0.1. If it doesn't, that's called a high PSA nadir. And in studies done with radiation and without radiation, it's an indicator of problems, that if you can't completely snuff out all the PSA production, it speaks of some cancer cells in the body that are able to continue functioning even in the absence of testosterone. That's not good news, because in the prostate cancer world, one of the reasons that we're so optimistic that people are going to do well with prostate cancer is that you always have the hormone blockade safety net that can put people in remission for 10 to 15 years easily. And if that is not going to be the case for this specific individual, this is a real problem. So we don't have enough information in this situation. It may be that he's only been on hormone treatment for 2 or 3 months, and a PSA of 0.2 would be perfectly fine. But if he's been on it for 6 to 8 months and the PSA is still above 0.1, then it starts to raise a question of whether there's some more a serious variant of prostate cancer here that would require more aggressive treatment.
So in that case, would you suggest a PSMA scan for just checking to see if it's anywhere else in the body, or would you automatically put him on a systemic treatment that's a different level of hormone therapy?
Yeah, I think it would be logical to do a PSMA PET scan. You can pretty much say it would be logical to do a PSMA PET scan in almost all situations now. In the old days, we would do CAT scans and bone scans and MRIs and look for, supposedly looking for where the cancer is, but the PSMA PET scans are so dramatically more accurate and sensitive that anytime a problem is arising, unless the PSA is completely undetectable, the PSMA PET scan is going to be the first reflex go-to action that's going to be implemented for on a routine basis going forward. It's nice to know they're being commercialized as we speak, that Medicare is now paying for PSMA PET scans, and I expect that the Blue Cross Blue Shield PPO insurances will be following soon.
Hey everybody, it's me and our dog, the PCRI mascot, Sir Hunter. You can go ahead and check out his Instagram, and go ahead and subscribe to our YouTube channel. We come out with new prostate cancer videos every week.